quiet. Where are your dogs?
Oh,
Your
they're
early
here.
warning system.
Just let something make a noise or move. You'll hear them.
Ah,
Oh man.
I can't get it. I just went in my settings and I switched it over. Let me try one more thing.
Well, I guess Ray's gonna be a shield today.
You know what? I'm not mad about it. That's fine. We'll go ahead and at least we got
Yeah,
the
sometimes you
at
just
least
gotta coach it, you
we
know?
got the Epi logo. All good.
Yeah,
Good.
exactly. It's not completely empty.
We'll make it work. I know our audience is very pissed off that they can't see Ray today. All good.
It's the beard. They can't see the glorious beard.
Oh man. All right, well let's go ahead and punch it.
Yep.
Uh, just a couple housekeeping things. Those that are joining in with us today, thanks for joining in. Today we're going to be meeting with Sam Prokop, who is a healthcare attorney here in good old Jacksonville, Florida. Um, she works for Gunster Law, which is a renowned Florida-based firm. Has extensive expertise in corporate and healthcare compliance, business formation, mergers and acquisitions, and navigating business disputes. Sam, welcome back. And
For having me.
for those of you that might have missed it, we have done another episode with Sam in the past. I'm going to post a link over in the chat. We were talking about some merger and acquisitions and all that good stuff. But Jose, I didn't know if you wanted to elaborate on today's topic that we'll be discussing. It was kind of
I
your
feel like
idea.
today is gonna be a little bit it's gonna be a little bit of scatter shot. So we're gonna try to punch quite a few things in the face, put Sam on the spot for a couple of them. Full disclosure, I did ask Sam the one question from last week, so we can go over that one real quick, just because it is football season and everybody's bloody getting hurt on my Rams team. So I gotta know what's going on
Oh,
here.
don't even get us started with the Jags now. I mean, we're in the same boat. We're in the same boat. Anyway.
So Sam, I got a question for you. And this one pops up every once in a while with my friends that are non-healthcare related because we'll watch a game or we'll watch, whether it's pro or even college. And the team or the organization will be more than happy to divulge all kinds of protected health information of these athletes, from where they're being treated, who's being treated them, what they've been diagnosed with, all that fun stuff. Now, they may downplay the severity of the injury, a lot of cases, concussions, we're talking about you. But but I was trying to figure out, and my friend was asking me, like, hey, and then we asked the question last week, how do how do they navigate HIPAA, and would those providers still be covered and not be able to say anything, even though the employment organization released all that information about their client?
Yeah, so good question. A lot of nuances here. A couple ways that can happen. So first of all, usually what we find with professional athletes, I won't speak to the NFL directly, but to any
Yeah.
professional athletes, just in general, when we look at contracts, their health is part of their job, right? And injuries are part of what they do for a living. So a lot of times in their contracts, they will have waivers where their employer gets to know. So typically, like with my employer being a law firm, they may have employer sponsored healthcare coverage. And in
Mhm.
some cases, if they provide self insurance, the employer themselves can be a covered entity. But generally, outside of that scenario of self insurance, an employer isn't generally a covered entity, right?
Yeah.
So they're not a provider, an insurance company, or a clearinghouse. Those are usually our
Yep.
three entities that are bound by HIPAA. So typically, we start with employers aren't. If they are providing some type of self-insurance plan, they could become the insurance company, in which case they would be a covered entity. HIPAA would apply, and then we need to meet an exception or get some type of consent or waiver. So one, we could be dealing with a scenario where HIPAA really doesn't apply. The second scenario is there's usually in the contracts, these athletes have to subject themselves to certain team doctors. They have
Yep.
to allow their employer to get that information. So that's usually just handled in a contract with the athletes and their employer.
So, I mean, and just one more piece to expand on that. I would that only cover the injuries related to my work within that contract. So for example, Brandon Marshall has been very open. He was an NFL receiver for many years, one of the greats. He had a lot of problems with bipolar and ADHD, but his teams weren't necessarily notified of that. And that caused some friction within the locker rooms, as someone with bipolar disorder can do and is effective at doing. So I wonder if there's a caveat or a carve out, or is it just a carte blanche that they got to know everything?
So again, not speaking to that specific scenario,
No,
but
of course,
in
of
general,
course.
typically your mental health type treatment and conditions,
Mhm.
there are certain things under HIPAA and even under state law that I call them, super protected information. So
Yep.
even though I signed a release or said, yes, you can release it, for instance, in Florida, there are certain things such as, so behavioral health type, mental
Mhm.
health type services, sexually transmitted diseases. There are certain things that are super confidential, and I have to actually sign a separate consent. A general HIPAA release isn't going to just cover that for purposes of state law. I have to sign like a separate consent saying, and you will note that I allow these things to be released. You'll notice in a lot of HIPAA consents, there's a couple extra boxes, right? Release just my records from this visit, release everything, release my behavioral health, mental health treatment records. You can release my STD, type information. So there's separate releases that have to go into that. So could be that it's super confidential. Second, if it doesn't impact the athlete's job, it's something that the employer may not have asked about. It may not be covered. When we talk about team doctors, right, we represent a lot of physicians who actually, do work or have contracts with professional sports teams. And there are, again, contractually between the sports teams and the physician, or even the physician and the individual players, there are certain confidentiality provisions, but there's also waivers going back and forth. So I am hiring you as the eye doctor for the Jaguars, and you have to give me, the Jaguars team, information about my players. And here is a waiver from my players allowing you to do that. As it relates to what we're talking about in the media, I would imagine probably between the players and the team or their employer that they're going to have some type of discussion from a PR perspective, right? When stuff happens, sometimes.
Yeah.
So my guess is if we're talking about it, it's going to be with something that's already gone public, or some type of waiver or consent. Somebody says there's an issue that's happened, I want to address it, I'm going to give you permission as the athlete to speak about this, or we're going to come together for a marketing strategy and get ahead of this issue. And so there can be consent provisions or voluntary waiver provisions of all of those privacy laws as well.
Okay. So then let's pivot this back into what are most of our clientele, both yours and ours, and the podcast viewership. We live in Jacksonville, Florida, Northeast Florida, and recently there was a hospital that got into a little bit of trouble with a surgeon that was conducting surgeries that should not have been. Is that something to where that hospital, I want to say it was Ascension, if I remember properly. There's that big class action surgery lawsuit, Ray. Do you remember which one I'm talking about? Came out like a year ago. About was it Ascension? It about bankrupted
I'm looking
the
it up.
hospital.
I
Because
think
it was an older surgeon that I got a condition with his hands or something, that so much so that the nurses in the surgery center were doing in the OR were actually doing the surgery, and he was kind of guiding them through when the shakes would get really bad.
was
And
he
the
an
class action,
orthopedic surgeon?
I can't remember if it was orthopedic. I know he worked with the hospital, so I wanted to say it was Ascension, but I can't remember.
It was Ascension. He was an orthopedic surgeon. I can put
Okay, there you go.
I'll put the link in chat.
There you go. So, Sam, would that be something where, especially if I'm a larger practice or I'm self-insured, where does that fall? Does that fall under HR, and we need a caveat for something like that? Like, how does that?
So this particular one, I'm not familiar with. It's not, but I can tell you, I come across these in the news in my desk every day with different types of issues. So this is not something new. I think there was one a few years ago where there was actually, I don't know if it was a resident or someone who had maybe filled out a medical residency, going around the hospitals, putting on a badge, right, and treating patients, and like nobody realized that the person wasn't even licensed. So
There
we
was a
see
Doogie
these all the
Howser
time.
out of Miami. There was a Doogie Howser out of Miami.
Yeah, there was.
doing it.
That's the one. That's what I'm thinking of. So it happens quite often. So when we're looking at this, when you're dealing with a hospital setting, this becomes really complex, right? Because when I go to the hospital and I get treated by a physician, some hospitals employ those physicians, but a lot of times they're not employed. The hospital is just the facility, and those
Yep.
physicians are contracted by an outside physician group that has privileges at the hospital. So if I'm going to look, right, if I'm a plaintiff's lawyer, I'm looking to see who can I sue, or if I'm a patient and I was harmed by this, who can I go after? I'm going to go after the deepest pockets I can find, and I'm going to go after everybody I can find. So I'm going to look to the hospital for a negligent credentialing claim, most likely. I am going to look to see, was there anything that I can go after the state for, which probably has immunity, but I'd be thinking through, like, could I have verified this person's license? Could I not? Was there information? You'll find a lot of times on these like public websites, the information's not always accurate, or these people end up losing their license and it doesn't get updated, or they might have lost their license in another state and it doesn't get reported to Florida. And so, because they're supposed to report and they don't. So there's a lot of ways this can go wrong. But what did the hospital know? Did they credential our guy that we were just talking about out of Miami? Like, how do you even get access to the hospital and security clearance if I'm not even an employee registered? I mean, I don't know all the facts of that, but like, those are the things that go through my, how did you even get in there, put on a badge and go see patients? How are you getting access to the computer and EMR? If that physician was part of a physician practice and they knew he had issues, there could be an issue there. We can look to his partners, his business partners, and other physicians. Sometimes under state law, there's mandatory reporting. If I know a physician is unsafe, or I know a physician has substance abuse issues, or I know a physician's otherwise violating the Medical Practice Act, depending on whether I'm MD, DO, DDS, whatever it is, there are certain mandatory reporting requirements as well. So there's a lot of different places to look for something like that.
And now, obviously, for clarity for everybody, different specialties are going to have different risk factors, right? Your orthopedic surgeon, your cardiothoracic surgeon, your neurosurgeon, they're going to have a high risk. If you got a little bit of shake, we got a big problem, all right? But I mean, if you're a primary care doc and you're just basically like, okay, yeah, here's the flu, get a Z-Pack. Oh yeah, here's this, go get, like, obviously there's going to be a different variance for these kinds of scenarios. But how do I, as a practice, protect myself from providers? Providers are also the worst patients.
Right. So in those scenarios, we hope you have some type of risk management plan. So at the hospital level, right, there's usually reporting, there's quality committees. They will look at morbidity and mortality outcomes. If I have adverse events, those are usually tracked, right? And for a surgeon, we have a lot more data and reporting, whether I'm doing this at an ASC or a hospital. From a physician's practice standpoint, it might take a little longer because in the office, I'm doing E&M visits. So do my partners know something's wrong? Do those nurses who were asked to potentially act outside the scope of their practice, they have a duty to report? So what is your incident reporting system, and what type of compliance policy do you have in place that says if I have an unsafe practitioner, I can report it? Who do I report it to? And then, on top of that, what's done about it?
So do you find in these scenarios, because I can see both sides of it, right? Or all three sides of it, right? The patient, the organization, and then the staff on the ground, right? Because if I'm the staff on the ground, me being a snitch, I may not have a job. Or if I do have a job, everybody's going to treat me like a leper. If I'm a patient, I want to know. I want to know if you had a cold last week. You know what I mean? Like if you got a migraine, I don't want you looking at my record. I mean, I've got a thin record. Can you imagine the ones that are Bible thickness? So and then obviously for the organization, I want to protect liability, but that could be one of my founders who does not want to take a step back, or it could be one of my new partners that I'm trying to transition the practice over to, that if he has this problem, that affects the entire organization's longevity and future. So how do we incentivize the staff to be proactive without making them feel that way, right? Like the patient's always going to feel like, hey, I can't help that side, but I can help the staff side at the very least, right?
Right. So a lot of that is, what are you doing to create a culture of compliance? And I don't care if it's a physician who may be impaired at some point and unable to safely practice, or if it's we may be billing something wrong or paying our marketers inappropriately.
Yep.
Key elements of a compliance plan. Number one, are you telling people what the process is to report? Do they feel comfortable reporting? Have you established a reporting, a kind of a chain of command and reporting where, let's say that physician's the sole owner of a practice. If he's the one you're reporting to and reporting about, nobody's going to report that, right? Do you have a confidential hotline? Do you have a third party that they can report to in a smaller organization? Have you told your staff that they have whistleblower protection and, essentially that you're encouraging reporting? And that's all about creating that culture of compliance, doing your annual training, top down leadership, right? Where the board says, we want to know, are you doing annual or even quarterly or monthly reports on concerns? Are you taking it to your board? Again, if you're a small organization, do you have an outside, maybe independent board or quality committee? For patient safety issues, you can join what are called patient safety organizations. There's special protections, involving kind of confidentiality in those. In the hospital setting, we have medical quality peer review. A lot of that occurs confidentially to a certain extent, right? Because we want people to be able to look at cases. We want physicians to be able to review other physicians, surgeries and say, was this quality care? Was this within an acceptable standard of care, without going, well, I'm not getting sued when I say this guy shouldn't have been practicing. So there's a variety of different laws, right? State, federal, that protect that depending on the setting. But really for smaller practices, the key is robust compliance plan and make it okay for people to report.
So and it's funny that you say that, because we've been talking about that, right? What, the last couple of weeks is just, we didn't mean to go culture, but it's super important for the culture to be right in the office. And I'm of the opinion, and I think you are too, Sam, that the culture within the healthcare industry, morale is bad and the culture is even worse in most places. And so if we can turn around the culture, turn around the way that people engage with one another, and perhaps teach some people how to engage with people, it would help for these critical and difficult conversations to go a little bit more smoothly. Yeah, it's wild though that you said pretty much the same thing. I didn't go as far as the boards, the external boards or anything like that. But that's really clever. I'm glad we have you on for these kinds of things.
I can tell you, even as a risk manager at a hospital, nobody ever wanted to see me coming, right? I'd walk down the hall and like, great, here comes Sam. But it eventually got to the point where
the 5'2" Grim Reaper, huh? All right.
Right? Exactly.
Did you do your training?
Pardon me?
Yeah. No. Oh yeah, did you do your training is what he said.
Did I do my training? Well, and it's interesting because everyone's like, oh great, what happened that Sam's here, the risk management department's here. But it eventually got to the point, when I worked in-house at a hospital, that I would go to the lunch line and I'd just be standing in the lunch line instead of eating my lunch in my office. And everybody would be coming up to me, hey, now that I see you, I have something I want to tell you. I want to do this. And so you could definitely see the culture shift there as people became comfortable reporting. I'm not going to get in trouble for this. In fact, the risk management department can be a resource for me. Or I'm not comfortable with what's going on here and I don't want a malpractice suit. How can we make this safer? And it was physicians, it was staff, it was maintenance people. And what I found too is just being visible, having somebody that people trust and can talk to. And that, that they know if they say something to, they're not going to jump down their throat. And something's going to happen in a positive way and maybe be an improvement. I think that's the key, and just being visible, right? Like I start going to lunch every day just because that's the only time I heard of, I'd never get an incident report, but heaven forbid I go stand in the lunch line and I needed a notepad with me.
I'm only recording this, guys, because I want to eat too. Okay. So I can play it back. No, it's interesting how all that kind of works out, because compliance is normally seen as a bad word, and it's part of the culture, right? Like I see that when you look at the hospitality industry and the main word being hospital, but you go to a hospital and everybody's kind of a jerk. Like it's a problem to deal with you. I'm the reason why you have a business. I'm the patient. I'm the patient's family. I'm a patient advocate. Like what is going on here? So it's interesting how that kind of works out. I know that stuff, and that there's tons of books and people talking about culture and how to fix it, but usually that stuff needs to go from the top down and then from the bottom up. But it has to go both ways. Kind of people that you bring in, how you train them, or lack thereof, causes a lot of the problems that top down they can't fix because they want to fix, but they just can't fix it for whatever reason. Cool. So, I mean, as we're talking about bringing people on, right? We're talking about some enrollment issues and some fraud tracking. You and I were talking about that. That could be a cool thing to see, a cool thing to talk about, rather. So tell me a little bit about what you've been seeing lately, because I haven't actually seen any of these cases, which is kind of surprising. But hit me, or hit us, rather.
So you're talking like as far as enrollment?
Yeah. The what you and I were talking about in email, like the scam is a lab company gets their MPI and signature from the facility medical
Oh
records
yes. Oh
and then
yes.
forges
So,
it.
so we've had a lot of interesting cases lately. A lot of grand jury investigations, OIG investigations, DOJ investigations. What they're doing is they're data mining, and they'll look at providers and they'll say, gosh, this nurse practitioner has a heck of a lot of COVID orders, like for COVID tests. And then she orders a COVID test, and then suddenly we're doing all of this pulmonary testing, and we're doing rheumatoid arthritis testing, and we're doing all these other things that don't seem to me to be like directly related, right, necessarily to a COVID test, or without waiting for the results. We're seeing this a lot in ALFs and ILFs. And our nurses a lot of times they've been nurse practitioners, and they've been newer nurse practitioners.
Makes sense.
To some extent. And so, and this happens to physicians too, but we've been actually defending these. What we find out is how this comes about is practice will get a request for a bunch of records. I want the orders for all these patients for lab work sent to this particular lab. Then on the other hand, the individual will also get a, we need to speak with you letter, or we need all your records for this. And then they call us and we say, well, of course, respond. And then they call me and say, well, they requested 30 records, but I've only seen 3 of these patients. Well, when we talk to the government, we'll call the government, we'll say, listen, who's the target of this investigation? Is it the lab, or is it my client entity, or is it this individual? And we're usually pretty upfront with what they're looking into. And, you know, a lot of times they're saying, we're looking at this DME company, or we're looking at this lab company. And we're also looking at your nurse, but your nurse, you know, if she's saying she only saw 3 of these patients, what ends up happening is they get their NPI, they get their signature on the EMR, and they're creating
the facility or the DME company gets the MPI.
We don't know. It can happen either. So we, you know, we're trying to figure out the extent. Is it the ALF or ILF? That is getting, because it's their EMR, right? So nurse practitioners, primary care provider, they go to see the patient. That ALF or ILF now has that signature on file, right? In the medical records, copy, paste it. A lot of times they will have preferred labs. We want all our patient labs to go to this lab if possible, because for whatever reason, we all know what that usually is. It's usually, you know,
they know a guy.
I know a guy, relationship. Or sometimes it's just easier for us to make a phone call and get the results we need, and they're really good. But we find that the nurse goes, well, I've only seen 3 of these patients. Or she looks at the orders and she goes, I would have never ordered all of this. I might have ordered a COVID test, but I'd never order this, and this. And they're like, well, you ordered 500 of them last month. And so what we find out is there's fraudulent orders, and it becomes an identity theft issue for the provider. And now all of a sudden our provider is sitting there with a government investigation. They're initially the target until they're ruled out as the target, right? And then they become the victim in an identity theft case, essentially. But what it's also doing is making them an outlier as far as what they're ordering. It's creating potential malpractice risk for them, right? If a patient, like, why didn't you follow up on these tests? Or patient dies in one of these settings. So it's this whole host of issues. We're seeing it in lab and DME. You have these companies, just essentially, they're fake companies. They're sending orders, forging records. And
where are they data mining this? Where are they data mining this information, right? Because there's certain information that we as organizations can do a better job of protecting, but due to the nature of the heavy regulations that exist in healthcare, I can find out damn near anything I want just by going to the board and typing in a provider's name.
So I will tell you, on the provider side, I say to these investigators, like, how do we protect the providers? Is there a way? So on the CMS side, how they're finding this is they said, why on earth is this one provider? Why have we paid out $200,000 for COVID tests in one facility? Or why on earth is everybody getting, you know, like this particular lab, which doesn't even make sense and is an outlier compared to others in the community? So the government is using artificial intelligence. It's same with insurance companies. They know what they're paying out, so they can see the trends. On the provider side, and if anybody has a good answer for this, we've asked the investigators, we've asked the DOJ and OIG, and they don't have a good answer for us. I said, what on the provider side can we do? Is there like a way that I can see my statistics and how many orders or how much money has been billed to Medicare under my number? And to my knowledge, there is not a good way for the individual providers to figure this out.
No. Because I mean, we've and on our side, since they've started doing this with the passage of the PPACA, using the algorithms to decide, oh, you're an outlier, Medicare prepayment review. Congratulations, you're going to be on here for the next 12 months, 50%, 75%, 100%. They would never give us the numbers.
Right.
CMS never gives you the numbers. I mean, it'd be an act of Congress to get that thing going, to get that information. I mean, I imagine a court subpoena would work, but you wouldn't be able to get that to justify getting off a prepayment review. Or if I'm a provider, it would also be a situation where I could be billing CMS for the same patient 3 times, from the ordering stuff for the home health, ordering stuff in the office for the day of the visit, and then the DME to go and supplement with the I mean, not saying that Miami is doing this, but you know,
no, but there's a reason in Miami, right? There was a moratorium on new home health agency enrollments for years, right? So it's been lifted, but like, this is why you have it. And on the other end of all of these payments is some company that has a tax ID number, that has a Medicare PTAN, that enrolled with Medicare, that filled out a CMS 855, whatever it is, to get enrolled, right? That Medicare approved and is submitting charges for completely fraudulent charges or based on completely forged orders. Ran into the issue with an orthopedic surgeon, several actually that I worked with, where after surgery, they'd order a back brace for their patients. And it was supposed to be paid for, and Medicare would all of a sudden come back to the patient and say, you owe us $5,000, this is not covered. And the patient's like, what do you mean? They're like, well, you can't have more than one back brace. I forget, it was like every 3 or 5 years, right? We only authorize one. They're like, I've never had one in my life. And they're like, well, guess what? Your doctor in Texas, Florida patient, ordered this for you 3 years ago. Patient's like, I've never been to Texas. I've never had a doctor in Texas. So they're taking the beneficiary information, ordering stuff, presumably getting paid for it. We have turned them in a million times, never heard any follow-up. I mean, the problem with this is there's so much fraud going on that Medicare and these investigators, they can't keep up with it.
No.
Well, my problem is this, right? Like, I sit here, and again, normally in my specialty, I'm sitting here with all this red tape to get things done, to do things properly, for people to turn around and do fraudulent crap and barely have to try. Like, it's wild to me. It makes it so difficult for me to sit here and be like, yes, we need to do things ethically and correctly, when the people that are doing things incorrectly are having such a good time figuring out new ways to do it easily. Because that doesn't sound difficult, right? Like, it's the 855I, cool. It's Medicare, so they're going to take it. It may take some time, but that's not very difficult. And as long as I'm paying the IRS on the tax side of things, it's going to take forever for somebody to pick up on what I'm doing. And then I just turn around and say, hey, this company doesn't really exist when you start looking into it, because there's a parent corporation somewhere along the way, you know, and good luck getting through all those veils, right? So piercing all those corporate veils. So, I mean, if I'm the provider, how are they getting my information if I've never even worked with them before? Is this something to where I could say, hey, if this happens, I can say, look, I don't even have a contract of employment with these people.
It's super easy. I mean, think about, so like nurses and physicians that go into ALFs and ILFs, right? You store stuff in medical records, they're sitting there. In the one case I have, there's actually charges now, so I guess that's public. We can discuss a little bit, but you know, how that one got figured out is it was the lab sales agent that was out there literally in an ALF giving the ALF's form saying, here is the form, the requisition form for the lab order. And the ALF was filling it out and handing it to the nurse practitioner saying, Sally Sue needs this test and this test and this test. Will you sign here? Now, looking back, when you talk to some of these providers, especially the newer ones, you're like, does that make sense? Should an assisted living facility that's really not providing any medical care, right, or very limited, right, or independent, should they be like giving you orders for you to sign? fine. And, in some cases they have providers there 24/7, right? Or personnel that are with the patient's sick, patient needs this, right? And I'm the provider going in once a week or once a month to round on these patients. I can see how it can happen, but providers need to be very vigilant in, why are we sending this all to one lab? Why is this our preferred lab? Do we really need all of these services? How am I verifying the patient really needs these services? Am I just signing stuff, or am I going in and doing an exam? So there's ways that providers can protect themselves, but it's so easy. You've got EMR, you've got data breaches. On the back brace example I gave you, they obviously have patient information, right? Somewhere with a PTAN in it. Like, there's been a breach or somewhere where they've gotten this patient information, socials, Medicaid, Medicare enrollment number, whatever, member numbers, to be able to fill out these forms.
Because I'm sitting here and I'm like, if they keep it up, Florida's going to come out with a DME exchange, like the E-forces here in Florida, where if I'm going to prescribe a class 2, I got to punch in the patient's name and see when was the last time they were prescribed any kind of medication and who prescribed it. It's going to be a straight up database. So before I can even prescribe them anything, I'm going to have to look at that crap. So now if I'm a GP, I'm sitting here like, okay, here's another database. I got to go look at the E-force. I got to go look at this thing and see what DMEs they have or don't have, to correspond with the conditions that I'm already treating. And sounds like a bloody headache, Sam.
Right. Well, and you would think even on the patient side, right? Did you not get an EOB 3 or 5 years ago saying you got a back brace and you're like, what the heck? Or did they put down a false address for you? Did it go somewhere else? Did it, it's really interesting. Am I an elderly patient? I'm not paying attention to this.
Sam, I'm 38. I barely open my mail. If it wasn't for the fact that my mailbox is a giant, big aluminum square, I think we check it like once a week, maybe. You know what I mean? And Caitlin and I are going in and out of my house all the time. So, and we pass by it 50% of the time. So, I have no doubt in my mind that people don't check it, or if they do, they're just like, oh, it goes with the marketing scam or this scam or that scam or the I can't tell you how many credit card. Oh, you're pre-approved, oh, well, it just goes out with that crap. So, and even if they have it, these patients, who knows how to read an EOB? I'm in healthcare. Look at EOBs all day and I can still barely read them.
Yep. No, there's a lot of gaps here. Definitely a lot of gaps. Don't know what the great solution is, but I think definitely if Medicare could come up with a way for providers to see, when am I the referring provider? When am I the ordering provider? How many of these have I ordered, right? Like, some way to look, not that everybody's going to track, but
no, of course.
How do I
but that goes back to
data? You're an outlier alert. Like, maybe people, I don't want to be audited. Maybe, why am I an outlier? Maybe I should look at this. Am I ordering too many of these? It would definitely be helpful, but there's definitely a lot of gaps. Do we need on-site surveys? Do we need, to make sure that these providers that are billing are legitimate providers?
Huh. So I know that we're reaching to just after 2:00, and I know you've got a hard out at 2:15. So if anybody's got any questions, jump in, type it into the chat. But while they're doing that, could this be a situation where, since Medicare is already moving to a model where they want to go value-based so badly, and they're already attributing patients to providers, they already have that process set up, is this something to where the patient would get a little bit more control or an outright notification? Hey, you've been seeing this provider, so therefore you are this provider's patient. You need something, it has to come from that practice or that provider. Is that something that you could see CMS just implementing because it'd be the low-hanging fruit?
I think the issue you're going to have is nothing is integrated, right? So CMS is a payer, TRICARE is a payer, Medicaid's a payer. Sometimes Medicare is my primary. Sometimes we have secondary payers on top of that. So, and so maybe I want an Advantage plan this year, and I don't want to be straight Medicare. And so is Humana talking to CMS, talking to, right? And then we have all these on the value-based plans. well, we've got shared savings program, we've got the ACO program, and we have this pilot program. And so nothing's really coordinated. So I think until we get IT systems, EMRs that feed, explanation of benefits, would it be great if we could somehow track patients and all of their medical care across these different providers, continuums, and payers? Maybe we can get somewhere, but I think I don't know that we're anywhere close to that.
You're talking about meaningful use stage 3. I mean,
well, and is that not
do you
kind of
remember
died,
that?
right? Like, is it not?
Yeah, you
That was
remember why they
actually
stopped at
talked of.
meaningful use stage 1.5 because they were like, problems with this crap, we could get that done. So I mean, California is currently, I just saw something, they're trying an information exchange, supposedly for something like this. So I imagine that if it flops, one side of the aisle is going to throw a block party. And if it succeeds, the calls for a national payer is going to probably get to an uproar.
Go back to privacy we talked about. What if I, as a patient, so we have right under HIPAA, I'm allowed to opt out of my insurance. And if I tell my insurance company, I want to be self-pay for this visit, and by the way, you are not allowed to give any of my medical records for this visit that I've paid for to my insurance carrier. What do we do with that, right? How do we balance privacy? Because maybe I, as a patient, don't want this shared with every payer I have. And then, payers, right? Now they have my pre-existing history, and we all know, right? But with the changes in insurance, like how that's used, potentially inappropriately to deny care. And what if I don't want this doctor knowing about this, that I went and got a second opinion? I mean, there's just so many different concerns from a privacy standpoint that I can see coming into play as well.
Well, and that's why they paused it 15 years ago, right? It's because of those, and then they were like, so you want to store all of the data in a centralized database that an innumerable amount of organizations and systems are going to be bridging into and out of. They were like, this is Wikipedia, stop it. There's no way to secure that data from well-intentioned or poorly intentioned people, just with all the breaches that have been happening when people are trying to protect it. Can you imagine just a cloud just sitting there ready to be plucked? I mean, and all you got to do is get a PTAN. Jesus Christ. That would be easy. I would just need to set up a PTAN or some kind of government corporation number and then be done with it and just be able to farm all day.
Another CrowdStrike.
It'd be worse.
Yeah, no.
100%. I mean, it'd be a buffet. I mean, think about it. If all I had to do was do a PTAN and then an IRS tax form that matches up, right? Like, you're 6 months, 9 months away from being able to farm the entire US population.
Well, and who wants to take liability for that? So HIPAA is one of the few laws I'm aware of. This is just my opinion now. This is not supported, but it's one of the only laws I'm aware of where I tell my providers, you're actually the victim. Your system got breached by a hacker, whatever. You are the victim, but you have penalties to pay. You actually have a price to pay for being the victim of some type of breach, no matter how good of a job you did to try and defend against it. So who on earth is going to want that liability to take this on to say, I'm now housing all this data, storing all this data without some type of immunity statute or something? Like, there's no way I want to touch all this data.
Someone's going to overpay. HHS is going to put an RFP out. They're going to overpay through the nose, and somebody like Change Healthcare is going to do it. That's how that would go. And we saw what happened with Change. Wow. So, I mean, all these exchanges, if you were able to do that, all these exchanges would lose their entire purpose of existence, and there's no way to further justify them, but they'll find a way. God damn it. They always find a way. I mean, now we send everything electronically. These exchanges still exist. They still take a % of every claim, and it's impressive. It's impressive. So, I mean, Ray, do we have any questions? I didn't see any.
I didn't see any come in, but I'm just curious. And I didn't do a whole lot of research. And we talked about DME fraud and stuff like that. What about on the telehealth side of things? I mean, that's got to be an avenue. Right.
I will let Jose. Jose and I have had discussions on this. Well, we've had discussions, right, Jose, with you. I mean, being part of a practice. I mean, in telehealth, that's so easy. So, what are your concerns there?
Well, my concerns are not necessarily, believe it or not on the telehealth side, right? Because unless you do this in the dumbest way possible, all of these video conferencing tools use a unique IPs for every single video conference. So this is the only people that have access are the people that created it and then whoever I sent it to. So as long as
True.
I have accurate information for the patient or whoever is going to be jumping on, the other providers, representation, whatever the case may be, I get to push liability off to that person because it's
How
not
do you
my
feel
fault.
though about like identity? Like, how do you know it's me or you're prescribing controlled substances or
That's kind of what I was
oh,
thinking. I was thinking like somebody posing as the provider.
So this is
yeah,
where,
even on that end.
yeah,
Yeah.
yeah. So Sam, you and I have talked about this. So this is where I go and say, regardless of what medication, if you're going to be prescribed medication, the first visit has to be done in my brick and mortar. Or a brick and mortar where you had to converse with a person on site and they had to get a copy of a license and your Medicare card.
Is
So
that your
this way,
protocol, Jose? Is that your
yeah.
protocol at your telehealth, or is that like sort of standard in telehealth?
So the DEA has certain regulations in regards to class twos.
Uh-huh.
However, on the admin side, it makes it very difficult to defend that we're not a pill mill if I say, oh, only class twos are coming in, because then they're self-diagnosing before they come in. No, we just go and say, look, screw it. You're a new patient, you're doing an eval, you got to come in. You got to come in for the eval. Somebody needs to see you, be able to touch you, be able to get your ID card, and then move on. Because at least there on our side, we're protected, right? Because we can say, no, I actually saw this person. If the pharmacy didn't see that person and went ahead and passed the drugs through, that's on the pharmacy side just as much as ours. So you got, and then the pharmacy's lawyers and then our lawyers like Sam would be like, hey, well, if we followed all the rules in play, it's not really on us. They found the loophole like you and I were talking about, Sam, right? Because there's a lot of things you can do with class threes that are currently with the DEA. You don't ever have to go to the office. I mean, the adjustment just with OUD and Suboxone. I can get my initial script, my initial 30-day script without being seen in the office. I can do it completely from telehealth. Can't do that for Adderall, but I could do that for Suboxone. Make that make sense, everybody. Come on. But that's a whole nother bag of tricks. Until those drugs are reclassified, that's gonna stay that way. But yeah, I mean, on our side, that's how we avoid any gray area that could get us into trouble, and then if there's any issues with the patient's information being stolen on the telehealth side, well, then close out how many devices have automatic access to your email, your work laptop, your home TV, your home tablet, your kid's phone. Like, close some of that crap out. That one friend that you were over at their house, oh, I gotta check my email real fast, and just stayed open. Like, the patients have to have some responsibility there as well, especially on a telehealth side. So, I mean, that's why you normally only see people that are tech literate moving into the telehealth all the time realm. I recently we had a patient actually complain that they had to come to the office for the eval. They just wanted to do everything through telehealth.
It's inconvenient.
I mean, I would love to do that personally, and we did do that during COVID because we could, but we can't do that now. Like, if you have COVID, we got bigger problems. You don't need to worry about your ADHD medication when you've got COVID, right? Like go get better and then come back. So, I mean, that's kind of where we're at. But no, Sam, I mean, I know this is your heart out, so I got to thank you for coming on again. I hope everybody kind of enjoyed. This was a little bit faster. I think we ran through every topic that you and I talked about, and we added one. So, Sam, I'm enjoying this. I think everybody else is enjoying it. We've been getting good feedback, especially from when you've been coming on. So, I mean, I'd love to have you back at least one more time before the end of the year if you're available. So,
yeah, let me know. The topic, or if anybody is watching, put in your questions or things you'd like to hear about, and we'll get something going.
Perfect. And then Ray, next week we have Dr. Delgado on, correct?
Yeah, next week we'll be with Dr. Delgado. We'll be talking about private equity compliance.
Ooh. maybe that's something we piggyback with Sam on afterwards in a week or so, in a couple weeks.
Absolutely.
So, she's always dealing with the private equities. She's always got something interesting going on every time I talk to her, you know, like that's the one thing you got to say. You never get bored, Sam, right?
I do not get bored. There is always something new and exciting.
So in other words, Sam can create like 10 more topics that she wants to talk about on our
absolutely. If for nothing else,
series.
because she wants to vent.
I'm fine with
If
that.
for nothing else. I mean, that one would be one. Whew. Whew. But yeah, so I mean, thanks guys. I mean, and I'm looking forward to what comes next with Dr. Delgado. The week after that, we have Ray. We have one of our Dawn gave us a topic. What was that topic? Do you have that one? Did you find that one?
No, I do have it. I haven't posted it yet.
And then the one after that, we were doing Tracy, and then we're into October. So
correct. So
fun stuff. We're almost in Florida fall. Sam, you ready for this? It's only going to go down to 85.
It'd be great. It'd be great for the horseback riding program. So
the sun's actually out today too. It's nice.
Yeah.
Yes. One day of no rain. It's been great.
It's been it's been a little depressing lately. I'm glad it's out today. But
well, you keep saying that, and then we'll have 90 days of no rain, and then you'll be like, "Oh my God, my grass is dying."
Well, that's how we started. It's spring, right?
I'm ready.
Yeah.
I'm ready for the change. Honestly, I'm ready. It's supposed to cool down earlier this year. Apparently, we'll see. It does feel good out today, though. It does feel good.
Oh yeah, it feels good. So, guys, I guess we're gonna call it. No questions from the team. So
I did put Sam's contact information. Feel free to get a hold of her if you have any questions. And other than that, yeah, we'll see everybody next week with Dr. Delgado.
Perfect, guys. Stay safe. Stay out of trouble.
Sam, thanks for your time. You take care.
You too. Take care, guys.
Sunshine.